بقية البرنامج بتاعنا النهارده في الإيجيبشن ريسبيراتوري كير سامت. هنبدأ إن شاء الله بمحاضرة بعنوان Lung Ultrasound as an Aid for Weaning. Is it an answer for all questions؟ دكتورة حنان مصطفى ودكتورة مي أحمد علي موجودين؟ اتفضلي يا فندم. اتفضلي نوري.
Assalamu alaikum. Good evening. I will try to speak as much English as I can so everything will be understandable. First of all, I would like to thank the organizing committee. Actually, being here today is an honor. My name is Hanan Mustafa. I'm an assistant professor of anesthesia, surgical intensive care and pain management in Faculty of Medicine, Cairo University. I consider myself very lucky to be here today. Actually, having an only women physician summit is a breakthrough. I heard about it, but I didn't believe it would happen actually. Thank you so much for the organizing committee and thank you for everyone who's attending today. And actually, it's my first time to be in Munofaya. In the last couple of years, I shared in a WHO mission all around Egypt to go to different governorates and explain a lot about critical care, but I wasn't lucky enough to attend in Munofaya, and I'm impressed. I'm impressed with everyone attending, how everyone is attentive, the great organization, and the very beautiful city. So hopefully it won't be long, and hopefully it will be useful. I will talk about a tool that I think is very popular in the field of critical care. Actually, I think it is very popular in medicine now. I'm married to a radiologist, so I know how popular it is. It's creeping inside everything inside the ICU and actually inside anesthesia too. So today, my talk has two parts. The first part is like a summation for the lung ultrasound usage in the intensive care, and the other part, I hope it's interesting enough, I will share it with my dear colleague, Professor Dr. Maya Ali. It's a debate, and we will split you into teams, Team May and Team Hanan, and stay tuned. First, I would like to show my appreciation to my home. And after the talk of Dr. Alia regards the ECMO unit, I'm more and more proud. I belong to this place, and I'm here today because I belong there. First, the dilemma of initiating weaning is always a debate. Who agrees? When will we wean the patient? After your morning rounds? Is this patient weanable or not? How debatable is this? For me, it's an everyday debate. Who agrees? Thank you. Lung ultrasound gained in popularity in weaning because, as I told you, it insinuated itself in the lung aeration, diaphragmatic function, airway readiness, hemodynamic stability, and actually it reached the response to respiratory physiotherapy. And I will tell you how. First, how do we integrate the ultrasound in the process of weaning from mechanical ventilation? Let me go through the day when you're going to your ICU and having your morning rounds with your team, and let's see what you do if you're having a patient ready to be weaned. When you check the weaning strategy, you stop your sedation, you optimize your hemodynamics and hemoglobin, and see the scoring and assessment for the respiratory function, okay, and see that the patient having an acceptable cough reflex. Then we start checking for clinical criteria for readiness with the spontaneous breathing trials and the setting of the spontaneous breathing trial on ventilator and the hemodynamic instability that it's not there and our target or saturation around 90 to 92%. And then you say, okay, that's a promising patient, let's think if we can wean him today or not. Sometimes you check for the cough leak test to check that there won't be any problem while taking off the tube according to how long this patient has been intubated and the cause that he has been intubated because of it. And then we start the confirmed readiness with the ultrasound, that there is no pleural effusion, no B lines, there improvement from your previous assessments by ultrasound, and the lung ultrasound score, and the diaphragmatic and intercostal muscle ultrasound, and definitely you will check the sister of the lungs, the heart, that everything is okay to proceed. And then you start your spontaneous breathing trial. Let's see where did the ultrasound jump into our routine in the day. Tuck, 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 tuck. It's all around the screen. Okay? So, does it still need more validation? Does anyone think that lung ultrasound as a role in weaning still needs more validation? Do you think so? Yes or no? Who say yes? شكرا. I think that too. Who say no? شكرا برضه. أي حد مش بيقول. Okay. Actually, this is one of many meta-analyses and systemic reviews saying that lung ultrasound is superior and it can help predict weaning outcome, and it has its accuracy that may depend upon the patient subpopulation. I didn't get them all because they are numerous and many. Lung ultrasound gained its popularity, as we mentioned, due to these 5 areas. I will tackle them very rapidly so as not to take so long, and the day won't be longer than it is. To lung irrigation, the very famous blue protocol. What is the blue protocol? Actually, the lung ultrasound relies on the air-to fluid ratio within the parenchyma to provide informative images in regions where air is entirely absent. As example, in consolidated, lung ultrasound successfully gives an image of the lung tissue, possibly indicating the presence of disease. Conversely, when air is present in the various image artifacts can arise. Depending on these artifacts produced, it can represent lung tissue with normal aeration, reduced relative aeration, irrespective of the underlying lung pathology. How did we make use of this phenomena of lung ultrasound within the lung? They started with a typical lung ultrasound assessment as we do, that they divided into 12 thoracic points, are examined 6 for each side, and the anterior and posterior axillary lines are delineated as references, subdivided each zone into upper and lower segments, and they started to plot this score as it appears. Okay, when we have for the pattern A lines and normally aerated lung tissue, the score is 0, and numerous B lines with longitudinal artifacts, some others decrease in lung tissue aeration, the score is 1. Having the numerous coalescent B lines in widespread areas within the intercostal spaces, and severe decrease in lung tissue aeration, the score is 2. And lastly, when there is lung consolidation and total loss of lung tissue aeration, the score is 3. So the total lung ultrasound score, the sum of these scores from the 12 thoracic regions we mentioned and were present on the diagram, with the lowest possible score of 0 indicating normal aeration in the lung tissue, and the highest 36 points in all regions. That was the first point where the lung ultrasound helped us, and we created the scores to be sure of the adequate lung aeration. The second cornerstone of using lung ultrasound in weaning from mechanical ventilation is the diaphragmatic function. Actually, the 3 main parts were, till now, that present are the diaphragmatic thickening, the thickening fraction, and the diaphragmatic excursion. And is everyone here familiar with the diaphragmatic function usage of lung ultrasound? No. Actually, in the Faculty of Medicine and Anesthesia department, we had like 3 to 4 research papers using them, and they have very promising results. I know that in literature too they have very promising results, but having our colleagues work on it themselves actually validated it more. So I think it's really promising. As a quick summation, deformation in the diaphragmatic function, we use a high-frequency linear probe placed on the zone of opposition where patient's diaphragm meets the thoracic cage, as present in the picture. The probe should be perpendicular to the lateral wall and placed between the mid-axillary and the anterior axillary line at the 8th or 9th intercostal space, and accordingly the estimated distance between the skin and diaphragm in this area ranges from 0.8 to 4.9. Sorry, the screen is not available. And then we measure the fraction by this equation. So the diaphragmatic exertion, the third cornerstone in the diaphragmatic function assessment, is measured using a low-frequency convex or phased array probe positioned on the front subcostal area between the mid-clavicular line and the anterior axillary line. Measuring the excursion can only be carried out in spontaneously breathing patient, as during assisted ventilation, passive displacement cannot be distinguished from the active displacement due to driving pressure. Previous studies suggested that this exertion cutoff values are from 10 to 13 millimeters or more, and diaphragmatic thickening fractions value of 20 to 30% of more than predictable successful extubation. As I mentioned, in where I work, it's now gaining popularity. I don't do it as a routine and I don't work it myself, but I think in the near future, with the presence of, with the more getting popular having ultrasounds in our ICU and getting more and more validation ways for weaning, I think it will be present on our everyday management. Anyway, after the diaphragmatic function, the tissue Doppler imaging, and it's one of the modalities used by the lung ultrasound. Actually, tissue Doppler is gaining too popularity in the radiology management, in the general radiology. Hence, it became more and more popular due to its presence when they found out that diaphragmatic tissue Doppler allows real-time assessment of the diaphragmatic tissue motion velocity, and that diaphragmatic-derived parameters differentiate patients who fail a weaning trial from those who succeed and correlate well with the PDI-derived parameters. Actually, I think it is quite logic when we know that the diaphragm shares in 70% of the respiratory drive, and that it's a muscle, and that we can measure it, and measure the displacement and measure the thickness. When we contrast it with the general skeletal movement of a human being, and how when he is in good state he goes around actively, when he's in a weak state or the muscles are not developed, we cannot walk properly. I think it's quite logic if we take it apart from the research and sciences and systemic reviews and everything and meta-analyses. It's quite logic that when we have a thick muscle that shares and contributes to 70% of the ventilation and oxygenation of the patient, that when it's weak or it's thin or it has any problem, definitely the respiration will be affected. Another two recent modalities in the ultrasound are the speckle tracking ultrasound and the speckle tracking ultrasound is an ultrasound modality known as a strain imaging. Involves the tracking ultrasound speckles over time, and these speckles represent the regions of muscle tissue with relatively stable gray patterns in the ultrasound imaging. It has a software, so some people are lucky to have it, some are not. We don't have it yet, but I had to mention it. By tracking a group of speckles throughout the contractile cycle and measuring their displacement and deformation in relation to each other. The other is the shear wave elastography, and elastography is a popular way of measuring how much fibrotic and how much active is a muscle placed in ultrasound. Ultrasonographers, they make use of it quite well, and it's now sharing too in the prediction of weaning that this technique involves the induction of tissue deformation through the generation of focused acoustic impulse beam by the ultrasound probe, and as a result a measurable shear wave is produced converted to shear modulus, and the higher it is, the greater the tissue stiffness. And this is a picture of both. What aids too in prediction of weaning, the ultrasonographic assessment of the parasternal intercostal muscle, which is, I think, is also promising and coming later. There are some very interesting studies using them. And the ultrasonographic assessment of the airway for weaning readiness, and that also was mentioned, the airway column width, it was mentioned in the diagram I mentioned earlier when we used it in the cuff leak test, and we had as an aid to predict will the weaning be successful or not. And the hemodynamic assessment through echocardiography, as I mentioned before, heart and lung are twin sisters. Whatever affects one affects the other. So having an ultrasound echo that aids us in the management and measuring the diastolic function and the left ventricular ejection fraction and right ventricular function definitely will affect the outcome of the weaning trial and the patient overcoming the stress of weaning. And lastly, surprisingly, the ultrasonographic assessment of respiratory physiotherapy, in which, for instance, cases where ultrasound imaging reveals lung consolidation, featuring fluid bronchograms in mechanically ventilated patients. Here, the ultrasound is of great use for the lung physiotherapists who can employ techniques aimed at enhancing expiratory flow rates. Throughout this process, lung ultrasound can be used to assess the efficacy of their management and maneuvers, and reductions in the size of the consolidation and visualization of air bronchogram instead of fluid bronchogram serve as indicators of the treatment's effectiveness. I would like to ask Professor, do you have them use it as an aid? No? Okay, thank you. So, let me go back to the title of our talk and start the interesting part. Is really lung ultrasound an aid for weaning? Is it an answer for all questions? And it's me again. Actually, we will split into two teams. Team Dr. May, which is a very optimistic pro team that sees that definitely every part of our next 9 questions is yes and good. And me, the pessimistic team, who will point out all the bad things in what we will see with evidence. So, you have to choose with which team you are. Let me tell you the 9 questions so you can prepare yourself. We will talk about the effectiveness in predicting weaning success, operator dependency, scope of application, comparison with other tools, standardization of protocols, generalizability across patient populations, role in multidisciplinary weaning, technological advancement, and cost effectiveness. Please be ready. Ready?
I'm all into lung ultrasound. In the late afternoon, I will present another presentation that reflects my total bias to lung ultrasound. So, of course, I totally agree that ultrasound can be effective in predicting the success of weaning, because there are several studies that have proved its high sensitivity and specificity in detecting success of weaning. In addition, we can use it to visually see the pathology, if it's still there or not. We can see atelectasis, we can see increased lung water, we can see static and dynamic air bronchogram, of course the pneumothorax. All these pathologies, lung ultrasound has great sensitivity and specificity, so I totally agree with ultrasound utility in successful weaning trials. Yes, definitely. It's a good negative, but specificity is very key.
The working, we just decide
أستاذ أحمد، بتاعتي حلوة ولا وحشة؟
Very simple, like the heart rate,
Doctor, you have to wait for the debate. I cannot hide behind المفاجآت. Let me take it from from our dear professor, and let me see who is on the cons team. Okay, actually, I see that lung ultrasound focuses primarily on the lung aeration, as Habatak mentioned, and fluid status, while other factors such as cardiovascular, as our professor mentioned here, stability, diaphragmatic function, neurological status also plays critical roles in weaning out. Who is with the cons team?
انا اللي ضد الموضوع كله يعني مش توتالي يعني partially يعني because يعني you know be realistic with me and ان شاء الله you will agree that clinically يعني 90% we are يعني this, our decision to win the patient by clinically and only يعني if there is doubt or the outcome is not good and we start winning at the after dawn يعني from AM 5 AM مثلا we will get the result at the end of the day at the لا بلاش at the end of the day midway at the end of the day we will decide if we will win or no.
Let us go, let حضرتك keep your opinion and tell me what's it in the end of the 9th point. I hope who will win the أكثر أصوات, who will be the winner with many opinions, the pros or the cons team.
Ultrasound is a portable television in our hands. Whenever we put the probe on the patient, we can see lots of wonders. We can add a lot of clinical sense.
Actually, in this point, we are draw because we have a lot of research and meta-analyses that shows that Dr. May is right and that the lung and diaphragm ultrasound can help predict weaning. And actually, there are a lot of evidence, as this very nice study that says that sometimes it was effective and sometimes it had very high re-extubation rates and problems according to it due to false negatives, as Professor mentioned. The second point, the operator dependency.
This is what I was about to say. It's all about who's using, for how long has he been using it. So I think that with sufficient training and proper courses, we can use ultrasound reliably and integrate it into standardized protocols, just like the blue protocol that you have mentioned, Hanan. It's a very nice protocol, just six known points on each side of the chest can help us very much to rule out lethal causes of morbidity, as well as whenever there are lots and lots of protocols that divide lungs into as much zones as you like. So if we can all adopt these protocols and get trained to them, why not? We can use it and integrate it to help us aid patient weaning. Why not?
That's the full side of the cup. Let me show you the rest. I think that the accuracy of lung ultrasound is heavily influenced by the operator's skills and experience. Okay, and that misinterpretation and variability in results may limit its utility, especially in less experienced hands or resource-limited settings. And I think that there's a big problem, not only that people are not trained. This is not the problem. Okay, ignorant people are not dangerous. The problem is in people who think that they are very good and they take very crucial decisions for patients in a very stressful condition and say that we are well trained, and it turns out that they are not, and they did not take enough training, and it's actually. So that's why I have to show the empty side of the cup too. Who is with the pro team and who is with the con team?
أنا مع الفاضي أنا مع
But the ultrasound itself is a huge difference in our practice. Nobody can say anything about the ultrasound in detecting an area of pneumonia or a pulmonary edema or pneumothorax or even the assessment of the fermented something else. But speaking about the training, you cannot say like what you say. Claim they are trained, tell them how to be normally are either trained or not trained. We have some measures to be sure that the training certificate, the time, next, particular problem that is maybe in your institute or in your department without judgment, without...
Actually, I don't see it in my department. I see it elsewhere. I work in a tertiary hospital, so we have a training program. I'm speaking that whenever you don't have this opportunity to train, please enroll in a training program. Okay, and by the way, this is not my words. I have papers that say that sometimes it's an overestimation. I don't say that we don't use ultrasound. The reason for this debate is solely not to list the advantages and disadvantages. Everyone will listen and then go out and there. I'm speaking to calibers, very pronounced professors. I'm speaking to physicians. I'm speaking to different people. So we try just to put them in an interesting way so that everyone will know the with and the against of everything, evidence-based. It's not my opinion.
Is a very crucial for the clinical care physician to use. So we are encouraged them all to be trained. And if you are really sure of the message, which is to announce for a training program accredited here in Egypt with a simple post أو يعني post أو حتى even the university can take care of the post. But at the end, it has to be certified and accredited.
Yes.
For all physicians,
yes.
About the, we are designing now a bundle, the bundle of the ECG, a bundle of what the physician has to do, has to be had. Like bedside tracheostomy, cardiography, assessment of the fluid, status by the ultrasound, the Doppler, echo, of course, for the emergency and blood ultrasound. This is one important area we have to address. We are trying to encourage you not to get into like...
No, don't get afraid. It's really a good tool, but use it wisely. That's all I think.
انا عايز اقول ان انا مع الكونز الحقيقه عشان انا راديولوجيست وعارف ان الاوبريتور ديبندنس ده بارير كبير بالنسبه للالترا ساوند انه يكون معتمد على كفاءه ومهاره الراديولوجيست او اللي بيجري الالترا ساوند. فانا قلقان برضه، انا قلقان من اننا ندي ابسوليوت كونفيدنس كده في الريزلت بتاعت الالترا ساوند في الحالات دي. في النقطه دي بالذات انا مع الكونز. انما انا عايز اكد ان انا مبسوط من طريقه البرزنتيشن وهي ما شفتهاش بشكل كبير، طريقه انترستنج جدا ليكوا الديبيت الجميل ده، فبحييكوا يعني على البرزنتيشن.
احنا ممكن نطمن دكتور محمد ان احنا خلينا ناخد الكونز دي and put with it have good clinical expertise, put with it the lung ultrasound, have a team in your rounds, and I think that the percent of being wrong will diminish and won't be that significant inshallah. Right. The third point is the scope of application. Dr. May?
Well, of course, I'll say yes, because I believe in the lung ultrasound. Maybe I can't say that it's purely primary, but it can be used as an initial step and complemented with others. After all, it's something at your hand. It gives you a real-time image. You can start with this examination without delay at bedside, and then maybe you can add complementary, more sophisticated radiological investigation to support. But being ready at your hand and easily interpreted with real time, I think this is great.
Okay, let's see if there is any empty part of it. The problem is that providing the information of the non-pulmonary factors, the cardiac function, except indirectly via the B lines, the muscle strength, or the metabolic issues. So I don't think this is a pure cons, but bear it in mind. You have a very useful tool, and you can use it, and you can train on it. But keep your clinical skills and your other confounders very vivid in front of your eyes. Okay? The other point is the comparison with other tools that aid in prediction of weaning. Is ultrasound, lung ultrasound, enough on its own, or should it always be paired with other modalities?
I can't keep optimizing to to the max. Of course, it has to be complemented with other modalities, but again, I see that it is very safe, it's very handy, especially for patients who stay for long times in the ICU. If you can spare them X-ray exposure, especially when they are children or pregnant, or unsafe to transfer, using the ultrasound is still very, very useful. I'm not saying we'll use it alone, we will complement it with other tools, but as a start, it can save their lives in many instances in a very speedy time.
Okay. As tools like diaphragmatic ultrasound or cardiac ultrasound may provide more comprehensive insights into weaning readiness, so they may one day overgrow the lung ultrasound, but till now, I think they are still babies and they need to grow. So that would والله يا دكتور كله evidence based والله من papers.
Never medicine that one decision is taken upon one investigation.
أنا ما قلتش كده والله.
It's all dependent.
يا دكتور أنا سوداوية بس مش الدرجات دي. أنا بيضتها شوية والله. أنا قلت بس يعني actually I wrote the prose والله. لا خالص it's all على فكرة all the papers are inside بس أنا عشان التايم مش راضية أحطه بس أنا I added all the papers. I did my homework immensely.
أقول حاجة في البروز يا دكتور. One thing that you will intervene using ultrasound. The great monster in the ICU, whenever you suspect pneumothorax and you can't find lung sliding, you might start by a needle thoracocentesis or sonar-guided thoracostomy until a cardiothoracic surgeon comes. Sorry? طب يا باشا هو الصناعة هينفعنا حلو.
هو جايب بس.
طبعا.
أيوه.
Of course, طبعا, of course. Yes, of course. بس in resource limited settings هنحترم نفسنا.
The coming point is the standardization of protocols. Okay, should we advocate for global standardization before adopting lung ultrasound as a routine tool? A lot of scores, a lot of protocols, and some guidelines are starting to put the lung ultrasound in its ways. So, what do you think, Dr. May?
I'm always into ultrasound. I know the FATE protocol, the RUSH protocol, the BLUE protocol, the lung zone protocols. All these are protocols that have integrated lung ultrasound together with even cardiac ultrasound. And I think all what we need is more training and more consensus within institutes on which protocol to use. With sufficient training, we can reach very satisfactory results. I don't mean that we are 100% sure, of course, or else we should use robots or AI. Of course, we have to rely on our clinical sense, and still there are medical surprises that can occur despite everything, but I still am very enthusiastic about using lung ultrasound during chest problem management in the ICU. Whether weaning before or after.
You are nearly about
Dr. May is gaining so much popularity and I might be kicked out in minutes. Okay, but different studies use varying lung ultrasound protocols, scoring systems. That's very right, leading to inconsistencies in interpretation and application because till now they are rising. We are in the storming phase. It's used in a lot of protocols, in a lot of guidelines. For distinguished people as you are, having an academic background, this is very nice. But I think the point حضرتك mentioned that we are putting bundles and creating like a step way that people can use bedside of the patient. I think this will be the step that makes the global standardization using lung ultrasound successful, inshallah, near. So the being generalized across the patient populations. Can lung ultrasound be generalized across all patient type, Dr. May? Please be some sort of
Yes, to a great extent. Of course, there are some confusions between something like ARDS and increased lung water or increased consolidation. It might be a little bit confusing, but it's still very, very effective to monitor and diagnose patients with different pathologies. And why not? Yeah.
I think I'm a winner in this point because its effectiveness is reduced in obese patients, those with subcutaneous emphysema, patients with pre-existing lung conditions like bullous emphysema, and I guess no one here didn't see an obese patient that has a bad acoustic angle. Why?
Every may have its limitation.
Definitely.
This is not the question. The question is it variable in every type of respiratory patient on the population that needs meaning? Every patient, this you have a list of limitation that will apply on both sides. But
Yes.
Outside the question is very variable in COPD.
Yes, it is variable in COPD, but if the patient has surgical emphysema, we are blind.
In every other situation,
دكتورة يعني
لا
surgical
والله عامة I'm very happy with this discussion because you made my point and I don't think anyone will forget the 9 points we are debating. Okay, and now I think this is the last one. Okay, the role in multidisciplinary weaning. What do you think, Dr. May? Does it have a role in multidisciplinary weaning?
Yes, as I said before, in the afternoon I will present a lecture about integrating lung ultrasound in weaning. We ourselves did it, of course I agree.
دكتورة مي يعني فاضل بس حاجة بسيطة وتقولي all things under one ceiling. ده ما بيحصلش يا دكتورة مي. You are absolutely يعني 100% with this is يعني
لا بصي ما احنا جايين نثير الجدل.
Yes, لا ما تثيريش الجدل. دي لايف سيفنج، ده لايف اوف بيشنت، ده جود، ده ديسيشن، ده شارب ديسيشن تو وين ا بيشنت. لان بعد الويننج اصلا بتحصل بلاوي ويو ار surprised to have many problems.
لا احنا we are not going to leave the patient and go home at all. بس انا بقول ان احنا we can use it usefully during all stages, when we admit the patient, during his clinical course, when he's near weaning, during the process of weaning, and after weaning, we will keep beside him using it. But it will give us quick, real-time messages that we can integrate into the clinical sense. I'm not that pessimistic. But I'm encouraging young people to get acquainted with ECMO, to hold the probe, and start fiddling around. It gives lots of information in a very simple way, especially in the lungs. In the lungs, it's much more simple than the heart or the vascular system. It's very nice.
surgical emphysema يعني اي واحد كان دايجنوز وزود التراساوند على طول يعني سبكوتينيوسلي كده وزي الفل والراجل جاي لك بتعرفيه من غير سوفيستيكيشن يعني. ده رايي انا الشخصي يعني.
في اخر 2 بوينتس احتمال احنا نخسر فيهم يا دكتور.
ايوه.
التكنولوجيكال ادفانسمنت والكوست افكتفنس. هو ده The technological advancements. Do you think in the lung ultrasound as an aid for weaning will be there with the technological advancements, Dr. May?
AI مش سايب لنا حاجة. AI interferes with any electronic monitor. It comes and interprets for us.
For me, the AI is still under investigation.
Yes.
It's a tool with no restrictions yet. So putting it in a decision for such an important decision is still under debate. But definitely one day it will be a winning course. The cost effectiveness,
كم دولار بقى؟
Okay. Actually, she's the winner here.
It's of course cheaper than CT, than MRI. It's cheaper, yeah.
Yes, but take care, there is a cost of training people, the cost of having programs, and take care for the time. People take enough time to train to offset these benefits in certain settings. What I would like you to go home with is that lung ultrasound is a valuable tool, okay? And capacity, its predictive capacity for weaning has limitations, particularly in specific patient population or in used in isolation. You need to put it in a multidisciplinary environment. To improve accuracy should be combined with other assessments such as diaphragm ultrasound, echocardiography, and clinical problems. I'm very thankful. If you have any questions, I'm so welcome. Last but not least, I would like to thank Dr. Alia and all the team I came with and the organizing committee again. Actually, Dr. Sharif Mukhtar is not here, but I have a word to say. I hope you tell him. Dr. Sharif Mukhtar was my first mentor for critical care. He saved the life of my dad when I was a medical student twice, when I was in the 4th year and the 6th year. And I used to look at him when he was managing the case of my dad as a Superman hero, actually with a cape. So when I went into anesthesia, I kept insinuating till I reached the surgical intensive care, trying to be around the heroship that he always does. Thank you very much. Sorry for being long.
It's actually not a question, but it's like a statement. I'm a pro lung ultrasound, pro like everything related to ultrasound. And just to state that the thing is here is not about should we implement this or should we not implement it. It's all about the protocols. It's an institution thing. I worked in places, not here in Egypt, I worked in places that you implement, all the people can work with ultrasound, but not just ultrasound. It's echocardiography, viscous score, all of them can do a viscous score. So you have a very vast and versatile people there. But lung ultrasound and the diaphragmatic ultrasound and all of these things, you can implement all of it and get not just a tool. I can say that the ultrasound is the new stethoscope in your ICU. So, yeah.
Yeah, correct. So I'm just not going to be adding the pros of the ultrasound, but as I mentioned, it's all about that we use this properly. Giving training to people is instrumental in using this in the ICU. And using ultrasound is not that hard. Yes, it's dependent on the operator. However, it's easier to work with. We are in our institution, and my colleagues here, we work with ultrasounds daily. And yes, I can say this patient has a pneumothorax, this patient has pleural effusion. However, if I put the stethoscope on the patient, yes, I can't hear anything, it's diminished. It can be atelectasis, it can be pleural effusion, it can be everything. However, if I'm looking into the ultrasound, I can say, yes, it's pleural effusion. Definitely it is. Without using an X-ray, without going to CT or anything. So, thank you for this lecture. And yes, ultrasound, we go ultrasound. Yeah.
ودكتورة مي على المحاضرة القيمة وفعلا interesting presentation. وشكرا كمان للانتراكشن من الاودينس، يعني اثروا المحاضرة ويمكن هم فتحوا باب ديسكشن طول شوية. فرجاء يعني السيشنز اللي جاية او البرزنتيشنز اللي جاية نلتزم بالوقت، يكون اقصر شوية عشان يعني تو سيف تايم.
برحب بالدكتورة لمياء حامد as the next speaker. محاضرة عن impact of information technology on healthcare with a focus on respiratory disorders. تفضلي دكتورة لمياء.
مساء الخير. good evening. أنا عارفة إن إحنا اتأخرنا already starting late، فأنا هحاول أكون as short as I can. أنا بشكر طبعا كل اللي نظموا المؤتمر. بشكر اللي فكر اصلا في الفكره ان يبقى وومن داي. بشكر خليل طبعا، انا علاقتي بمحمد خليل قديمه قوي من ايام الدكتوراه، كنت مشرفه عليه، عزبته وعزبني. انا الحقيقه حاسه ان دي اهم مومنت فور مي ان انا اتكلم عن اي تي ان هيلث كير، لانه 1990 دكتور شريف مختار decided to hire a young doctor that can handle IT in the ICU. He did not have a clear idea what about my role and my colleague. I have a colleague. 1990, we were 2 doctors hired at Dr. Sheikh Mukhtar unit to make an IT system. This is exactly what he said. He said, I want an IT system. We didn't have fund by that time. He said, you're not going to touch the patients. You're going to have master and doctoral degree in public health and preventive medicine. This is your way to learn statistics and maybe IT. I went to the public health department. They did not have any idea about health informatics or IT in healthcare. So I had the doctorate in public health. I finished my master in 1997 using statistical methods in predicting outcome of critically ill patients. I used to tell Dr. Sheikh Mukhtar, everyone is concerned with the definition of the disease, the etiology, the symptoms, the signs, the diagnosis, and no one cared about the prognosis. And that was my mission. I need to tell the patient, his family, where this disease will take you. And in 2000, I told Dr. Sheikh Mukhtar, we use the statistics. Said, Master, I want to use artificial intelligence. He told me, are we done with the natural intelligence to use artificial intelligence? It was very new terminology by that time. He said, when are you going to learn AI? I said, I will have a diploma in AI, and then I will make my doctoral degree. I went back to Qasr Al-Aini after a year studying IT in healthcare, especially AI, in a governmental institute called Information Technology Institute that is affiliated to Ministry of Communication and Information Technology. I came back to public health department. I want to make my doctorate. They said, who is going to govern and judge what you're going to do? We don't understand computer. We don't understand AI. We have to hire a professor from Faculty of Medicine that knows AI just to judge your work. I went to Faculty of Medicine of Engineering, and I have to find a doctor who will approve to supervise a doctor in Faculty of Medicine. And it was a long journey. Ultimately, I had a doctorate using AI in predicting outcome of patient with heart failure, and I published this, and I won a prize in Conference of Cardiology 2001 as the first one of the best researchers in using AI in healthcare or in cardiology. To establish the system in the ICU, we didn't have funds. You know, like every health organization, they care about securing medicine, securing supplies, but securing IT infrastructure is not their first priority. So Dr. Sheikh Mukhtar told me, you have to find the fund. I granted the fund from the Ministry of Communication. We had like £8 million, not in money of course, it was like, you know, the establishing the infrastructure, choosing the software, migrating the old data, and then training the staff at Qasr Al-Aini in my place to establish the HIS. So it's a dream for me to talk about this because before, no one did understand. They thought at the beginning, it's a secretarial work. Doctor touching keyboard, it's a secretarial work. Now it's a discipline, and actually I teach in a private hospital, in a private university in Cairo, health informatics. Now it's an integral part of the curriculum of healthcare, that people should know healthcare in IT in healthcare. Of course, no one debates the importance of integrating IT in healthcare. It will increase efficiency of delivery of care, it will reduce cost, it will give better diagnosis for the patients, accurate prognosis for the patient, and better resource allocation. Today I will explain like 10 examples of using IT, of the innovative IT solutions in healthcare industry. These 10 innovations are, I will read, mobile health, electronic health record, telemedicine, interoperable healthcare information technology systems and wearables, the cloud and data analytics, the 3D bioprinting, AI, robotics, and blockchain. I know this is difficult at 4 o'clock. I will try to be simple and give examples from life that facilitate understanding these technologies. Mobile health. Myself, I shared in creating the first product in Egypt of mobile health. It was a clinical trial using like mobile phones to monitor patient arrhythmia using a mobile phone. So the doctor can see remotely the heart rhythm of the patients. And this was with young students, I teach them, and we surveyed the market for the need of this product, and it's successful now. I think they sell it in Gulf and Ministry of Health bought so many devices from this. The market share of mobile health, has increased. You can see, you can see like the industry is growing. Mobile apps are now an integral part of healthcare delivery. I hope in Egypt it will be same. This is US study. They try to see the impact of mobile health in pulmonary care. Patients with COPD, mobile health impact very much the follow-up of patients. Patient can readily access the doctor can readily access the patient follow-up. This study has shown like improvement in the delivery of care, improvement in symptoms, the quality of life, and hospitalization has been decreased using mobile apps. Actually, there is another study that compared 3 mobile apps, of course, in US as an integral part of delivering the care in a polyclinic in US. And they proven that 3 mobile apps were very effectively used by the patients, accepted by the doctors, and it impacted the prognosis of the patients, and it decreases the hospitalization and weight of outpatient clinics. The second innovation, the electronic health record. We have in Qasr Al Aini a cutting-edge electronic health record that Microsoft has acknowledged as best practice in the Middle East in governmental hospital 2014. Of course, the electronic health record has so many impacts on the delivery of care, on improvement of patient outcome, reduce cost, and reduce the redundancy in paperwork. Of course, there are so many challenges in the implication or application of electronic health record. One thing is the burnout of physicians. They have a lot of work to do, and they don't have time to record every single transaction. And the interoperability between the direct patient care or point of care and other facilities like lab, pharmacy, outpatient clinics, and billing. All these interoperabilities are difficult. But now there are so many innovations that made electronic health record on mobile apps, so doctor can readily access or record all transactions at point of care. Now there are so many applications that tackle the pulmonary problems in COPD, asthma, and lung function tests. The third thing is telemedicine. We all familiar, COVID has proven that telemedicine had solved so many problems for patients. When we had like the lockdown, patients could access doctors through mobile apps, through even WhatsApp. So telemedicine had done a lot to deliver care without, having the hassle of visiting the doctor in their clinic, especially in pandemic settings. In pulmonary care, there are so many studies that telemedicine intervention could significantly reduce the risk of emergency department attendance and hospitalization. Wearables, now wearables are, everywhere. I like to say this quote from Dr. Chad Gatling, who said practitioners have to be able to react to trends, not just data. Because we receive so many data now from, the mobile app, the Apple Watch, and all these things. It's not only the heart rate, it's the heart rate, the blood pressure, the sugar, the calories, the exercise. All these things need to be interpreted collaboratively and over the hour, These are all wearables, it receives data from every part of the body, and we need to deal with all these data to deliver a decision, and this decision is based on so many information. Wearables in pulmonary care, I like this study that, could affect the prognosis after lung cancer surgery, and it proves like the technology that is, now booming is cloud computing and data analytics. We're all familiar with data analysis, but analytics is a different thing. Analytics is, deriving insights from the already analyzed data. And, data is the thing that we collect data from so many resources. For example, in the patient in the ICU, we have the clinical record, we have the ventilator data, we have the monitor data, we have the lab, we have the drug sheet of the patient, we have even the cost of his medications, we have every single blood gases all these are big data that are coming from different sources over the hour, and these data to be stored and managed, having like physical hard storage is difficult and is time consuming, space consuming, and it's costly. Now cloud solves this problem. We save our data on cloud and it's easy accessible. The only threat is security, but people deal with these securities by private clouds. And this innovation, I don't know, we will live to see the impact of it, the 3D bioprinting. 3D bioprinting will solve the problem of organ donation. It's a special printer that prints on the living tissue. And it's like we are manufacturing organs in labs, and these labs and these organs that we manufacture will impact the drug trials, because we can try the drugs on human organs. It will affect the organ failure, the lung transplant, all organ dysfunction if you need transplant. They are trying to manufacture organs through this Leila, she said we are trying to mimic the breathing process. She says the ultimate goal is to have structures similar to human airway and lung tissue, to have them surviving and interacting with one another in this artificial environment. We will be able to biochemically track what happens when the trigger of disease, like asthma, makes cells behave in a certain way. They are trying to see the disease in can you hear me? They hear. He's sleeping. It's a difficult topic, what I can do. Huh? That can be innovations. AI, as my colleague just said, AI is now an integral part of any healthcare delivery system. AI, we have in the ICU our system a decision support tool that can, trigger the drug-drug interaction, the drug-lab interaction. It determines the dose of the medicine based on the weight, the height, the underlying conditions, the lab profile of the patient. This is sort of AI. We have AI in every single, ICD is having a decision support tool.
Nothing was there for us.
Nothing is left for you as a human. You're welcome. This is AI, as you can see. It's in every single part of the healthcare industry. This guy? Who is this person? Kevin Piat is a tennis player who had a severe accident, ended in paralysis. But with robots, he could walk in hand in the flame. Robots now have, so robotics in medicine will change the face of medicine later. Robotics emerged in 1980. Robotics are used in so many things, and as Rhea is a robot that helped a lot in a hospital, and the director of the hospital said Rhea does not check her phone. Rhea does not get tired. Rhea does all jobs without being bored. So Rhea is more effective than humans. Actually, of course not, but I like the term augmented intelligence, like us and the robots and the technology. The human and the technology will do better. These are examples of robots that are in the ICU and an operation room. In pulmonary care, of course, robots has a role in so many things, like biopsy of the lung and so many things. Finally, the blockchain. This is, every single transaction in a hospital is a unit. Dealing with all these data coming from every single transaction is called a blockchain. And that will change the industry in healthcare later on. My take-home message is we have to build the capabilities of personnel that can deal with the emerging IT to mingle with healthcare and deliver best practice in the world. Thank you.
Thank you, Dr. Lania, for this elegant and valuable talk. وقعدنا في البيت فعلا بتتهاد. ده كده يا باشا مش هنروح المستشفيات تاني.
لا ما
شفنا ده يا فندم في الكوفيد كان بيجيبوا البلس بسيطة كل شوية الصديق ده نزل كذا ده كذا. ده 80 ده كام مرة
ما هنقول حاجه احنا في ميزه وفي عيب. The advantage is you will have the data cumulative and so many data. So we will, as I mentioned earlier, you will study the trend, not the data. The trend is very important, and you have to teach your patient. The trend is important, not the individual value. You will tell him we care about the average over 24 hours. So that he will. Not only that, you have patients that they live in remote sites and they cannot access you. And telemedicine wearables will solve the problem of these patients. Of course. طبعا to save exactly.
طبعا يعني بشكر حضرتك على المحاضره الرائعه دي، بس زي ما قال الدكتور خالد ان هو هيقعدنا في البيت، بس هل احنا هنستفيد منه واحنا على النقابه هنا ان هو هيعافينا من المسؤوليات الطبيه؟ يعني
هي طول في الاخر has to ما هو احنا how we train. For example, when I did my doctoral degree, I trained the AI model on patients. So it's me who trained, who supervised the learning, who delivered the results. I believe it's as Dr. Shikar used to say, it's a catalog marriage between IT and healthcare. Marriage. It's not like someone part that replaces the other. It's not. It's.
ليه بقى؟ بالتالي في هاز وهاز ماستر مايند ما تاخدش مسؤوليه وتنفذه ولا هي جايد
And that's why now احنا بنقول على ايش كان زمان فورس.
هم بره كتير يعني تلاقي ايه؟ دخلت اوضه العمليات تلاقي مش عارف ايه فني العمليات ادى امبول لازم وخرج عشان هو الشيء بتاعه خرج خلص ساعتين اليوم بتاع التلفزيون ده بتوصل للمكنه الساعه مش عارف ايه جدا. الفنيين الموجودين تبص تلاقي القضيه اخبار تلاقي فيها 500 واحد. اسمها ايه؟ شركه تامين شايله كل طبعا شركه التامين بتبيع فور اول.
لا شركات التأمين شركات insurance companies they don't pay now all insurance companies they have like some conditions. The hospital has to be accredited at least in Cairo in Egypt here. They verify all claims before approval. Actually, I was part of a company that made a tool to judge the claims. It's a US company. You know Visita? Are you familiar with Visita? The founder of Visita? He traveled to US and he made a company to help doctors claim their money because the claims used to be denied because it's not complete. So we created an AI tool to manage the claim and pick the points that are wrong and it returned back to the doctor and to the patient to be corrected for him to gain his money. Just one thing. Technology will deal with the huge amount of data, giving insights insight. Now we're not talking about data analysis, we're talking analytics. Analytics means it gives insight what to do for the patient, not just the description, this is critical from that. It's insight, and this is the trend now. معلش.
The next speaker is Dr. Dina Rojdi. We will speak about non-invasive ventilation. Overview and
معلش بس ادوني دقيقة قبل الدكتورة دينا. أنا محمد طارق مدرس طب الحالة الحرجة جامعة المنوفية. في دقيقتين بس لإعطاء يعني كل واحد حقه. بعود بالتاريخ لسنة 2007 2008 وسنة كنا في سنة 5 طب. كان الدكتور محمد الشافعي ربنا يمسيه بالخير أستاذ طب الحالة الحرجة في القصر العيني كان بيدينا كورسات هنا في البطن. كان بيحكي لنا عن وحده الدكتور شريف مختار وقد ايه الوحده ديت الاكشن اللي بيحصل فيها والصور واحنا في سنه 5 مش متخيلين كل ده ممكن يحصل في مصر. ربنا كرم في 2011 الواحد تخصص اي سي يو كان لسه بنتكلم يعني ايه كريتيكال كير ميديسن. المكان الوحيد ريفرنس كل كريتيكال كير ميديسن في مصر كلها هو وحده الدكتور شريف مختار كليه طب القصر العيني. بالتعاون مع عميد الكليه ورئيس الجامعه تواصلنا مع الدكتور شريف والدكتوره عاليه كانت رئيسه القسم ساعتها. وكان لينا الشرف والفخر ان احنا نتعلم على مدار 3 سنين او 3-4 دفعات ورا بعض مع اساتذتنا الدكتوره عليا الدكتور شريف الدكتور اكرم الدكتور خالد الدكتوره لميا وكل الاساتذه وما زلنا على يعني لغايه دلوقتي هم ريفرنس لينا وبنتعلم منهم. وربنا كرم بعد كده وربنا خدنا ماجستير ودكتوراه وبقينا ندي ماجستيرات ودكتوراه بس ما زالوا هم ريفرنس. وجودهم النهارده انا بحب اشكر الدكتور محمد خليل على المجهود الرائع اللي عمله ان قدرنا يعني اللجنه المنظمه الدكتور شريف يدينا محاضره دكتور عاليه دكتور اكرم وكل اساتذتنا من القصر العيني وكل التشيل بيرسونز والموجودين دكتور احمد دكتور محمد دكتور احمد بصراحه في بيت الاطباء هنا في المنوفيه مع دكتور احمد دياش بصراحه يعني فرصه ما بتتكررش كتير. وطبعا بس زي ما وعدنا دكتور محمد ودكتور احمد ودكتور علي انها هتتكرر تاني ان شاء الله باذن الله تعالى. فبس انا اسف للتعطيله دي بس الدكتوره دينا دفعتي في القصر العيني وبدانا الطريق مع بعض فانا قلت اخد منها الدقيقتين دول. مفيش مشكله.
ام كي يعني محمد خليل كريم طبعا.
I am Dina Zaida, lecturer of Critical Care Medicine, Critical Care Department. Thanks for the organizing committee for inviting me today. Thanks for our mentors in ventilation and the Critical Care Department. It's a quick wrap up for the non-invasive ventilation. It's a rather long day. I will shorten my presentation as much as I can, with highlights for the most take-home messages I just want to emphasize. Administration of ventilatory support without using an invasive artificial airway, it's called an intertracheal tube or tracheostomy tube. This is the non-invasive ventilation. The last decades have witnessed an extension for indications for non-invasive ventilation for acute and chronic lung diseases, evolving advancements in technology and AI for our personalized approaches to patients, making more feasible to prioritize patient-centered care models, as Dr. Alia mentioned, and Professor Sharif Mukhtar always told us about its patient care center. First of all, what's best practice? Treatment that is accepted by medical experts as appropriate treatment for certain condition, widely used by healthcare professionals, what we name standard of care. We always think of positive pressure ventilation. There is something called negative pressure ventilation. Can anyone suggest?
Hello? Hello? Hello?
In the polio epidemics in 1920s to the 1950s, the patient's body was encased in iron cylinder and negative pressure was generated. This was the negative pressure ventilation tubes, أو بيسموها chest. Nowadays there is curious ventilation by Dr. Zamer. It's used in cardiac patients as a biphasic curious ventilation with external high frequency oscillations. It's used in anesthesia and acute respiratory failure. used in weaning from invasive ventilation, significant ventilatory weaning where pulmonary compliance and airway resistance are relatively normal and the limitation factors is respiratory muscle weakness. It can make good sense as patients of amyotrophic lateral sclerosis. The things I witnessed in chest physiotherapy and secretion clearance, the cough assist device, high sequential procedure can be programmed in the modern day QRS ventilator. For muscle weakness, it had the same modes as the normal ventilator, as controlled by phasic at the intermittent mandatory ventilation, continuous negative equivalent to the CPAP, non-invasive synchronized as to the SIMV, high frequency oscillation. This is applied in up to 100,000, 12,000 oscillation per minute to achieve oxygenation, reduction of carbon dioxide, and there's some device cardiac synchronized. This is the physiology and the clinical benefits of the non-invasive ventilation and post-pressure ventilation. Neurological improved encephalopathy due to hypercapnia, avoid continuous sedation, and pulmonary, we just get on. The key to successful application of non-invasive ventilation is recognizing its capabilities and limitation. Identification of the appropriate patient, contraindication, patients with absolute coma, cardiac arrest, respiratory arrest, any condition requiring immediate intubation, cardiac instability, GI bleeding, intractable bleedings, inability to protect the airway, status epilepticus, potential for airway obstruction, extensive head and neck surgeries or any tumors. Patient inclusion criteria should patient cooperative with tachypnea more than 24 breaths per minute, with increased work of breathing, hypercapnic respiratory acidosis, hypoxemic, the PF ratio less than 200 millimeter mercury. Indicated in chronic obstructive pulmonary disease, cardiogenic pulmonary edema, immunocompromised state, post-operative respiratory distress, and don't intubate status. Subtle clinical conditions after discontinuation of mechanical ventilation, acquired pneumonia and asthma. Another indications also with neuromuscular disease, decompensated obstructive sleep apnea, cystic fibrosis, rib fractures, used with cautions in idiopathic pulmonary fibrosis and acute ARDS, considered helmet ventilation, and as also to not delay in intubation. Complications of non-invasive ventilation, skin irritation, pressure sores, muscle discomfort of some patients, dry mouth and nasal congestion, gastric distension, aspiration, aerophagia, and pneumothorax. Long-term and ventilator-associated pneumonia and nasal bridge erosions. Interfaces, as Dr. Ojdo mentioned. Characteristics of the ideal non-invasive ventilation: leak-free, good stability, non-traumatic, long-lasting, non-allergenic, silicon, low resistance, minimal dead space, and with acceptable cost. Securing team, it has to be stable, easy to put or remove, non-traumatic, light and soft breathable, works with various interfaces, washable and disposable. This is the type of masks. This is the helmet. Okay. Types versus modes, we know as the continuous post-pressure airway pressure, the CPAP. We're almost familiar with it. The bi-level. The bi-level non-invasive ventilation augments respiratory flow throughout the flow or timing cycling and achieving optimal support and synchrony. When approach is to set an initial EPA in 4 to 6 with titration up to 8 to 12 to achieve consistent triggering, and respiratory 8 to 12 with up titration for acceptable tidal volumes and respiratory rate. We can here set up a backup rate. This is one of the volume assured pressure support. This is one of the AI or the intelligent now volume assured pressure support ventilation, as Dr. Lamia mentioned. This is one of the new modes in the non-invasive ventilation, where the pressure support is a proprietary algorithm to provide assured circumventilation by learning the patient's waking breathing pattern on minimal EPA 4 centimeter water to a maximum 15 centimeter water. The nasal high flow cannula. Which is clinical applications as acute hypoxemic respiratory failure, pre-intubation oxygenation, post-extubation, post-operative respiratory failure. For acute hypoxemic respiratory failure in immunosuppressed patients, a post-hoc examination of the FLORALI study indicated that among immunosuppressed patients, non-invasive ventilation was associated with more frequent intubation and higher mortality than conventional oxygen therapy for or high flow nasal cannula. Updates and innovation, non-invasive open ventilation. Patient-triggered tidal volumes are delivered during a nasal Pano-style cannula with 2 Venturi-type air entrapment ports. This is the open system, non-invasive. Patients with chronic respiratory failure who need non-invasive home mechanical ventilation can become deconditioned because of exercise limitation. We can use it for during exercise. Non-invasive ventilation, both bilateral and CPAP, has many indications across acute and coronary, improved respiratory muscle function and improvements in breath, quality of life and survival. In the future, technology advances in non-invasive devices will make them more user-friendly, portable, and customer to meet specific individual patient needs. However, don't delay your decision to intubate your patient whenever you think of it. Thank you.
شكرا جزيلا دكتورة دينا. شكرا محاضرة. لا حد عنده أي سؤال؟ طيب هي دلوقتي لاست سيشن. دلوقتي احنا لاست سيشن في البداية، هنبدأ السيشن الجديدة إن شاء الله بإذن الله. شكرا جزيلا لحضراتكم. نبدأ السيشن الجديدة إن شاء الله. هنفايت التشير بيرسونز سيشن 4، بروفيسور دكتور عادل الأنصاري، بروفيسور دكتور خالد فاروق، بروفيسور دكتور رباب الوحش، بروفيسور دكتور أميرة رضا. اتفضلوا يا فندم.